evening. I must apologize for the late start to tonight's program, but all the same, you are all very welcome to Let's Talk About Health. We are live on Facebook and YouTube, and I just want to welcome all of you. I know a lot of you are trying to link up, so you are welcome. And I must say we have an incredible session loading up this evening, so I would like you to phone your friends and get them to listen into this program because it promises to be amazing. Last 2 weeks, we had Dr. Matilda Isan here in the studio, and she looked through infertility in men and women. It was an awesome session. I watched it back and I thought, wow, that was really great. So if you haven't watched it yet, it's online on Facebook and YouTube through my page and of course through Omega Live TV. All this is coming to you by kind courtesy of Omega House Multimedia and of course World Remit, the safest way to send money to your friends and family back home, especially in Africa, in Ghana, everywhere you can think of.
Yeah.
Tonight we have Dr. Robert Khan. Dr. Robert Khan, the last time we were here looking into hypertension, we had over 6,000 views.
That's amazing.
On that program. So I am really looking forward to this one. Please share, so we can get more and more people to watch this show. Yeah. Dr. Khan, you are welcome. Tonight we will be looking at diabetes.
That's right.
And then I remember all through this COVID era, we have been hearing about all the comorbidities, and diabetes is one of the major ones that is highlighted, especially for those of us who are of black and ethnic minority group. So I will let us start and get the ball rolling by looking at the pathophysiology of diabetes like we always do. Pathophysiology of diabetes. So if we can have the producer to project like which part of the body are we talking about when we are looking into diabetes. I think that would be a great start. So we know where we are. Before we go on, I'd like to say a big thank you to all my fans out there. I know so many of you are giving incredible feedback. So many of you are contacting the team of doctors and health professionals who come here to feature, and you send all your questions, and we try to give you the answers that you need. So I need you to keep doing that through Messenger, of course, so we can together help, encourage, and boost people's health through a show like this. So I think we will go straight on point and look at like diabetes. So if you don't mind starting for us, please.
I think that before we even start talking about the diagram, it's important that we do this. As you rightly said, during the COVID period, you would realize that a great number of people who died, almost a lot of them had one of the underlying conditions they had was diabetes. And diabetes has been implicated in many diseases as well. So it is not a condition on its own that just sits there. Once you have it, it affects different organs in the body, and that makes it so dangerous. In addition to affecting a person's immunity as well. Now, back home, people like to, even though this is an international program, because we're catering to so many different people who are not from
back home, from Ghana, like say from an African
kind of setting. When we used to be in Ghana, you would realize that people would call it sugar illness.
Right.
Yeah, you remember. And then sometimes people would say that, whenever I pee, I see a lot of ants or flies or whatever around it. They knew that there was sugar, some sort of sweetness in the urine, but they didn't know what it was all about. And that spawned quite a lot of herbalists and so many people selling different products. Now, when you look at this diagram that is there in the body, you've got, if you look at this beautiful diagram here, you would see a label there that says the liver. And then you see the gallbladder. Ignore the portal vein. You see what we call the duodenum. Okay. You see the esophagus up there. Essentially, when you eat, you put food in your mouth, and after you've chewed.
The duodenum is part of the stomach.
Part of the stomach. So I'll come there. I'm starting from the top. The esophagus is like the tube that carries the food that you've chewed into the stomach. Here you don't see the stomach, but the stomach is usually almost wrapped around. You see where the pancreas is sitting at the top there, and then the esophagus leads into the stomach. The food gets into the stomach. it sits there whilst acid works on it. I should actually have had a diagram of the stomach. Whilst acid works on it. Now it breaks it down after, let's say, about 2 to 3 hours. It becomes a bit more loose or softer to the point where it can now pass through the duodenum, which is the next part of the digestive system. Now in the duodenum forms almost like a loop. Now in that junction,
that's what we are talking about.
that's what we're talking about. Okay. So that portion you see is like a cut portion. So it's a tube. You've cut the tube into half. Okay. You've got this organ there sitting there called the pancreas.
Yeah, is this green leafy one?
That's right.
About? Yeah.
I mean, some people call it green. Well, men are colorblind, isn't it? So I'll call it. Is it yellow or green or whatever? Yes. Yeah. So this particular little organ there is very important because it plays quite a crucial role in digestion. It produces some chemicals we call enzymes, and at the same time produces certain hormones. Okay. Now, for example, if you eat carbohydrate, irrespective of the meal that you eat, it produces enzymes that can break down the fat, produces enzymes that can help break down protein, and then it produces enzymes that break down carbohydrate. In addition to that, it produces insulin.
Right.
Now, if you take the whole body, every tissue in the body is made up of cells. So we would call the cells maybe the basic unit of a tissue. Okay, it's almost like you've got a blockwork, and the individual bricks are like cells. Okay. Now the cells need nutrients for energy, and usually the nutrient for the cell is glucose. So whether you eat fat or you eat protein or you eat carbohydrate, essentially most foods are broken down to the basic unit, which is glucose. It is glucose that can enter into the cell for energy. Carbohydrate is the quickest source of energy that the body depends on. Even though in the absence of carbohydrate, as we see in the ketogenic diet, for example, somebody could just depend on a diet of, say, protein and fat. But it's a long process. It takes a long time to break down the protein and the fat before you get to the glucose unit. And this is why carbohydrate is so important. Now the pancreas is very clever. In the pancreas, when you cut it, there are different types of cells in there. One of them is called the beta cell. It is the beta cell that produces the insulin. Now the body is clever. The body is designed such that in the abundance of plenty, when there's a lot of food, the body stores it. It will store the extra in the form of lipids or something called glycogen. It stores it in the liver, in the muscles, adipose tissues, certain areas. And the reason it stores it is that when there's no food, when you're hungry, in famine, maybe in starvation, then the body breaks it down slowly and releases it as glucose. So the cells constantly have a source of energy. Now the cells need a certain environment. So even the glucose that the cells need, it has to be within a certain range, a certain amount. If it's too much, it can damage the cell. If it's too low, the body experiences symptoms. And the body is clever using a mechanism, it's the physiology of the body, to maintain the glucose level within a certain range, which is safe for the cells to use. What insulin does, that's the hormone we're talking about from the pancreas. What insulin does is that once you've eaten your food and the food has been broken down into glucose, food goes through the duodenum, then it will go into the small intestine. By that time, it's become liquidy and it's broken down from whether it's complex carbohydrate, proteins, or whatever, into the basic units called glucose. Glucose needs to leave the blood and enter the cell. Now, without insulin, the glucose cannot enter the cell. So the insulin is almost like the cell has something we call receptor. A receptor is almost like a lock to a door. It's the insulin that opens that lock so the glucose can enter into the cell. Is that clear?
That is clear.
That is why I like what we are doing, because it's very important people understand what is going on in the body, because it will be very important in management of the condition.
That's right. Sometimes you go to see maybe your GP or the diabetic specialist, and they start talking about your insulin, your pancreas, and this, but people don't understand what it does. In 3 simple steps, you eat your food, it's broken down, or your carbohydrate, it's broken down to glucose. It's glucose that the cell needs for energy,
Yeah.
so that the body can carry on with its basic functions. For the glucose to be able to enter that cell, it needs insulin to unlock the cell so glucose can enter. And this is the whole mechanism. When something goes wrong with that mechanism, then the person then develops diabetes. So you have the insulin, and that is why when you come to type 1 diabetes, type 1 diabetes, even though we say that we don't know the cause, it is attributed to autoimmune disease, for example. So the body's own immunity or immune cells would destroy its own cells. In type 1 diabetes, which is a type of diabetes, because we have type 1, type 2, and then other rare forms as well.
I think you have said the scene beautifully.
Yeah, that's right. Yes.
To build on. So my next question was actually going to be: are there types of this condition at all?
Yes, there are types. So the type depends on what is happening to the insulin.
Right.
When you take type 1, the pancreas is not producing the insulin because the cells, the beta cells that I mentioned, are damaged.
Right.
In the pancreas. If the beta cell is damaged, it cannot produce the hormone insulin. But the person needs the insulin. Otherwise, it means that all the glucose that you're producing stays in the blood. It cannot enter the cell.
Right.
And once it stays in the blood, it is going to cause
a lot of damage
in the body. So this is why in type 1, the patient is on insulin because they lack insulin.
They don't make insulin.
They don't make insulin.
Right.
So they need insulin. Then in type 2, which is normally happens 80 to 85% of the underlying risk factor for type 2 diabetes is obesity.
Right.
Weight problems. So in type 2, insulin is being produced, but the cells are not sensitive to the insulin. So you have your
sensitive at all.
they are not sensitive. We tend to use the word resistance, insulin resistant. So I'm producing the insulin will get to the cell, but there's resistance. It is not, for some reason, it's not working. The cells are not responding to the insulin. So the person is producing the insulin, the glucose is getting to the point, but then it is not working. And this is where, in the majority of cases, you would give your metformin, the gliclazide, and other medications to aid the glucose to enter. That's right. That's right. To control it, controls the sugar levels in the blood, and then assist the insulin so that the glucose can enter the cell. So you have type 1 where you're not producing at all, and then you have type 2 where either the quantity is small or the cells are unresponsive or less sensitive to the insulin.
Right.
That's right.
Okay.
And then so type 1, type 2, and then we have gestational, which a number of women are aware of. Gestational means pregnancy related.
Yeah.
In gestational diabetes, we use the term diabetes, but actually you tend to find out that it is not full-blown diabetes.
Right.
Part of the screening, antenatal screening, is that you have your blood sugar done. And in the majority of cases, this is where it is picked up. Because until the woman is pregnant, maybe she's not even had any symptoms at all. She's young, in her 20s, in her 30s, never had symptoms, but then she goes to the antenatal clinic, they do blood tests. Maybe the midwife tests the urine and says that no, there's glucose in the urine. And then she would then organize some fasting blood test for you, and in the great majority of cases, the value that comes out may not necessarily be diagnostic of diabetes, but it shows high levels of glucose in the blood, and that has to be managed because it has a risk on the baby. If you don't manage it, mother ends up with a very big baby, and the complications of trying to deliver a big baby, the complications to the baby, complications to the mother. So gestational diabetes is also one. The thing with gestational diabetes is that quite commonly, if you're told that you have it, then make sure that you have follow-up. In a great majority of cases, once the woman has had the baby, the sugar levels they drop down to normal. It doesn't mean it's gone. It means the risk is there.
Right.
It is why the lady would be told that 6 weeks after you've had the baby, check into your GP and have your blood sugar levels done to make sure that it's dropped to normal.
Okay. So are these the only types of
no, we do have type 2 normally accounts for up to about 90% of diabetes that we manage. Type 1 accounts for up to about 8%. And then the other 2% are attributed to other rare causes. So, for example, if somebody is on long-term steroids, let's say prednisolone, there are conditions for which patients would have to take steroids, sometimes for life. That predisposes you to diabetes, because steroids itself boosts sugar level in the blood. So that is steroid induced. And then you have, for example, there are medications that we use to manage mental health conditions. Patients with, say, schizophrenia, psychosis. Are you with me? We call them antipsychotics. Some of those medications have a risk of increasing the blood sugar level as well. And then there's a particular condition we call MODY. That is maturity onset diabetes in the young. This is a very rare genetic condition. We don't normally tend to see it. It runs in families. And it is said that it is because of mutation to a gene. When we say mutation, it means that the person's genes or DNA, something has happened to a portion of it, which has made them prone to developing what we call maturity onset. So as the person is growing, that is when it starts to express itself. You would hear the term MODY or MODY. So those are the main types. Sometimes you might go to see maybe the nurse, you go for a checkup, they tell you that there's sugar in your urine, and then you go and have a test done. When the test comes back, they say you have borderline diabetes. And a lot of people don't understand borderline. We used to use terms like what do you call it? Intolerant, IGT, or glucose what do you call it? I've forgotten the terminology. We use fasting glycemia, increased fasting glycemia, which is the person is not diabetic. Are you with me? But has borderline diabetes. In those cases, we just monitor or impaired fasting glycemia. It is impaired because it is not normal and the person is not diabetic. So we would monitor every year. It depends. I tend to monitor usually every 6 months.
Is it the same as
pre-diabetes? That's right. So we're using the terminology pre-diabetes to cover impaired glucose tolerance and impaired fasting glycemia as pre-diabetes, between normal and abnormal or full-blown diabetes. And I'm saying this because sometimes when patients come and you say that you've got borderline diabetes or pre-diabetes, they take it for granted. You tell the person that, look, I'll use a typical example. We use something called HbA1c to monitor how well the disease is progressing. And the person comes and you tell the person that your HbA1c is, say, 45, which is pre-diabetes. I would want to, because you feel thirsty a bit these days, or you're peeing a bit more at night, instead of waiting for a year, I would want to test it in 6 months' time. The person disappears. Sometimes you don't see them again.
For the ones who you said, the pregnant women, is it an indication that they will have diabetes in the future?
Yes. The risk is that if they don't make lifestyle modifications, the risks are high. And that is why we advise that monitor afterwards, every year, at least check in. And then anytime you go to see the practice nurse or go to the surgery, at least we can test the urine for you as well, to make sure that you're not developing full-blown diabetes, but your risks are increased.
Where does juvenile diabetes sit in all of this?
Juvenile diabetes
young, isn't it?
That's type 1.
Type 1.
We used to call it juvenile onset diabetes or childhood diabetes, but we limit it to type 1 diabetes, simply because if the person is not producing insulin, you tend to pick it up when they're very young. And quite commonly, the typical scenario, the parent says that, or maybe Kofi keeps getting a lot of infections, a lot of upper respiratory tract infections, getting a lot of skin conditions. Kofi is always unwell. Kofi is eating, but is growing lean. He's not putting on weight. Kofi lacks energy all the time. Kofi looks fatigued all the time. Kofi pees himself quite a lot.
And how young can they be for it to be picked up?
I have a patient who is 6 years of age.
Type
1,
6 years?
Yes.
Wow.
Yes, I have a patient who is 6 years of age, fatigue, not thriving, what we call failure to thrive.
Right, yeah.
And if a child is failing to thrive, and the one thing with type 1 diabetes or childhood onset is that quite commonly the urine is loaded with glucose because there's no insulin. So the commonest test we do in clinic is a urine test. Particularly for me, any child that is unwell that is brought into clinic, I would always find a way to test the urine.
Yeah.
I don't assume that it is just a cough and a cold and a snuffle and a chest infection. Especially if I look at the history, at the trend, that this child is coming in virtually almost every month with an infection, unwell, I would always test the urine. And that's how we pick it up. Yeah.
Juvenile, wow.
Simply because with the juvenile ones, if we don't pick it up on time, the child will die.
Yeah.
They develop something we call diabetes ketoacidosis, DKA, which we just...
So as young as that?
Yes.
Oh, wow.
Yeah.
Well, viewers, if you are just joining in, we are live on Facebook and YouTube through Omega Live TV. And the session is amazing. Diabetes. We are looking at diabetes. So far, we've been looking at how it starts and what actually goes wrong in the body to get to a diabetic state. And then we've looked at some of the types, type 1, type 2, touched on juvenile diabetes and gestational diabetes in pregnant women. We are going to carry on. I am your host, I'm Mrs. Winnie Ohine-Kisi, and I say if you haven't started sharing this, please share, get your friends involved, forward it to them, send the link to them, and keep sharing so we can get more and more people involved in especially this session, because it's one of the comorbidities that we have mentioned so many times, especially in this COVID era. I have Dr. Robert Khan with us, and he has always been backing me in doing this program, and we will carry on with the session. And who is at risk? Who is at risk of...
Before we even come to the risk factors, let me share some information about prevalence. As to why is it so important that we talk about diabetes. WHO, or World Health Organization, is stepping up the effort. Even in this country, we're stepping up the effort to pick it up, to treat it, to manage it. All the health jargons you hear that people should exercise a bit more, stay active, stay fit, walk a bit more, eat healthily. It is all geared towards preventing diabetes, preventing cardiovascular diseases, because naturally as we grow, activity levels drop quite commonly. Our lifestyles become more sedentary, driving more, and now with increased technology, we're even exercising less. Previously, you would walk to your local kebab shop and buy your, what do you call it, Turkish delight. But now, yes, just eat. You just press on the app and it's delivered. Press on the app and something is delivered. You pick a phone, you call. Now you can even order through your TV. Well, there. So all you have to do is just sit at one position and eat yourself to death, basically. So we're trying to prevent that. We're trying to get more people off the sofa and then watching their health a bit more. Now let me give you some interesting statistics here that I picked up just today because I wanted to make it more current. In 1980, worldwide, there were 100 million people living with diabetes. In 2014, it had increased to 422 million.
Wow.
That's right. Between 2000 and 2016, 5% increase in premature deaths were due to diabetes worldwide. And unfortunately, it affects, as you know, the low to middle income countries such as ours. Most of the countries in Africa fall within that category. And diabetes is a very expensive condition to manage. We're blessed in this country where at least if you have diabetes, you don't pay for medication.
So what could be accounting for that? Is it because of just our basic staple foods,
That's
which
right.
are essentially carbohydrates?
Yep. It is. And then again, when we come to the risk factors, who is at risk, you look at the statistics, unfortunately, the Afro-Caribbean, yes, we are topping the chart. So you would see that there are certain conditions that are prevalent in the Afro-Caribbean and Southeast Asian population. Diabetes is one of them.
Right.
Because, for example, our risk of developing diabetes compared to somebody who is Caucasian is 2 to 3 times the risk higher.
And it has genetic constitution part of it. Possibly.
Otherwise, how else do you explain it? A family history, if there's somebody, immediate family member like a father, a mother, a brother, a sister who has diabetes, so I'm already going into the risk factors. Then you are highly at risk of developing the condition, diabetes. Obesity tops the chart. So you would see that almost all the conditions that we've been talking about, being overweight puts you at risk of cancers, of diabetes, of heart disease, of stroke, of cardiovascular diseases, so many different things. Being overweight. So it is not an advantage to anybody to just gain the weight, keep on gaining the weight without any breaks at all. And I say this because, you see, now we're fortunate that we've got NHS, which is free at the point of care. I'm afraid I would be surprised if this would be free in the next 10 years. No. I mean having free medical care in this country.
The system is getting overwhelmed, isn't it?
Well, the truth is that ask yourself, where's the money coming from to manage it? Because we've taken it for granted. Everybody thinks it's free. The money has to come from somewhere. A lot of it is borrowed money. I don't know whether you know how much debt this country is in. It is not as it seems. Now, the topic of getting people to pay for health care is another debate on its own. People would resist it anyway. But I'm sure we will get to that point where people would have to pay, like the Americans. You may have to pay something for your health. Now, if now you've got into an age where maybe financially you can't afford health insurance, you've not looked over yourself very well, okay, you're planning on retirement, what do you do? And you have diabetes, what do you do? And I'll come to the statistic, because it's a condition that it takes its toll on the person. If you're here at the moment, you're blessed because you get all the care for free. You don't pay a penny. And on top of that, when we give you your prescription, you don't pay.
When you are diabetic.
When you are diabetic, you don't pay for medication as long as it's written on the FP10, the green prescription that we give you. Yeah, so we have a lot of our diabetics would call, I mean, for paracetamol, for ibuprofen, for whatever, because they don't have to pay for it.
Obviously, a lot of our viewers are watching from all over the world.
That's right.
So
if you're in Ghana, when I used to practice in Ghana, I mean, it was terrible. I mean, to even be able to afford insulin or to afford, the person might be able to afford, say, metformin for the first month, for the second month. After a few months, the resources required to manage the condition is too much for them. So you see that they start giving themselves drug holidays. Are you with me?
Drug holidays.
Yes, because they can't afford. They can't simply afford to buy the medication to manage the disease, because it's not just affecting one organ, it's affecting multiple organs. It's affecting multiple organs. Okay? So obesity is number one in terms of risk factor. Aging.
Age.
And that is why for years you tended to see, for example, type 2 diabetes, which forms 90% of diabetes, tended to happen as people grew older, normally after the age of about 40. Now the trend we're seeing is that age is coming lower and lower and lower, because now we have a lot of young people who are unfortunately obese already, increasing their risk of developing type 2 diabetes even when they are young, late teens, early 20s, mid 20s. The age gap is coming down slowly, and that's the risk, that if we're not careful, we're sitting on a time bomb, that in about, say, 15, 20 years time, if this trend continues, it will be difficult to manage it. That's right.
So in terms of men and women?
Yes. Interestingly, women are more at risk.
Why?
Than men. I don't know, but we are also at risk of certain things more than women. But when a man gets it, you know, I don't know whether it's an ego thing. I don't think it's ego.
It's more difficult to control.
It's more, yes, because we're not compliant with medication. And if a woman comes in and they are diagnosed with a condition, many of them would take the medication religiously. But with the guys, I don't know whether we don't believe it, or a lot of times they'll tell you that it was my wife who pushed me, nudged me to come in. My wife was very worried, and sometimes it's the missus who books the appointment for him to even come in to have the check done. Otherwise, he'll just be there until complications already start. But the risks are higher in females than.
Could that be hormonally related? Or there is no evidence to support that?
There's no specific evidence to support that. Just as you would say that most men are more prone to heart attacks at a more younger age than women. Again, if you read the evidence, it will tell you that estrogen has what we call cardioprotective factors. It protects the heart, isn't it?
It does.
So you tend to see that women become more prone to heart conditions after menopause.
Exactly.
60s, 70s, whereas for men, it is a bit earlier. So maybe the makeup of a woman and the makeup of a man, there are factors we have that protects us against certain diseases. There are factors in the woman that protects the woman against certain diseases. The truth is that as we grow older, there's a leveling, and we're both sexes are prone to the condition.
You did mention about like noticing children failing to thrive, for instance, and then being lethargic and being very skinny and all that. How do adults identify that they have diabetes?
This is where the demarcation comes in. You would, in type 1, you would see the person also has. When I come to the symptoms are the same in type 1 and type 2, except that it's more profound in type 1. Whereas type 2 is linked with weight gain. In type 1, weight loss.
Okay, can you go over that again? Whereas
in type 1, the person is losing weight. In type 2, the disease is there because the person is gaining too much weight. And it's less active. So this is where the distinction comes in. So sometimes when we're even making the diagnosis, especially let's say the person is in their 20s or early 30s, sometimes you wonder, especially if you find ketones in the urine, and then is this type 1, is this type 2, then you want to do other investigations to establish if this person has actually developed type 2 or type 1, because some people are diagnosed, they are adults, but they require insulin right from the word go. This is where the confusion is. But in type 1, it's clear the person is losing weight because glucose is not getting into the cell. Energy is not getting there, so they are losing weight. Nutrients are not being laid down. They are eating. They feel thirsty. They feel hungry all the time. They are eating as much as they can, but they are not thriving. Whereas in type 2, well, polyphagia, the person is eating and eating, but they are putting on more weight. And it's the weight that is actually making the cells less sensitive to the insulin that the body is producing.
I mean, people would want to know, I mean, once they have all these symptoms, how is it diagnosed?
Let me go to the prevalence first. Before. And the reason, as I said, we're talking about it, is that we want people to get to the point where they manage their health better. Nobody knows tomorrow. You may not have the resources to have a health insurance. You might not even know where you might be. You might probably have retired to Africa or back to where you came from, and suddenly you're diagnosed with this condition and you don't have the resources to manage it. So prevention is now. If we look at the UK now, at present, there are 4.7 million people in the UK who have been diagnosed with, in the UK alone. This does not include those who have the symptoms but have not come forward to be tested. So these are diagnosed cases. In 1996, it was 1.4 million. In 2019, we have 3.8 million. As of now, it's 4.7 million.
Going up and up.
It's growing up. 1 in 15 adults in the United Kingdom has diabetes. 6 in 10 people are diagnosed with no symptoms at all. So there are many people who we pick up opportunistically. So the person came to clinic, say Mr. JB comes to clinic, says that, I'm 46 years of age, Dr. Khan, I've not had any checks done at all, so I'm just popping in to have a health check. So instead of just checking the blood pressure, which he came for, I would always take the opportunity. And I said, whilst you're here, why don't we do your annual MOT? So give the person a port.
So very accidental.
Very accidental, opportunistically. 6 out of 10 are picked up that way.
Oh dear, yeah.
She gets pregnant, she goes to antenatal clinic, urine is dipped, it picks up the glucose. Or she goes to see the practice nurse, she thinks she's got UTI, cystitis. The practice nurse says that, can I test your urine? She tested, there's glucose in, and says that no, there's sugar, maybe 2+, 3+ in the urine. We should do a fasting blood sugar test. and then the person ends up having a blood sugar test, bingo, and then you have a diagnosis.
Yeah.
So we pick it up. So anytime people go to see the GP, my advice would be use that opportunity. Have your urine tested.
Yeah.
It doesn't take more than 10 minutes to have the urine tested, and it'll give us a lot of clue as to what is going on.
Right.
It is said that every year in this country, there are 10,350 people who develop end-stage kidney failure as a result of diabetes. About 100,000 cases of heart failure each year as a result of diabetes. 35,600 cases of stroke just in the United Kingdom attributed to diabetes. 27,000 heart attacks as a result of the complications of diabetes each year. 1,700 people develop serious eye problems in this country as a result of diabetes. It costs, in terms of cost, it costs 10 billion a year in this country
alone.
That is the 10% of the entire NHS budget, which is 10 billion, is spent on managing diabetes, and 80% of this 10 billion just goes to manage the complications of diabetes.
Yeah.
The eye problem, the kidney problem, the heart problem, the stroke.
I think we have a diagram of all the systems that are usually...
Yeah, when we come to the complications, we'll talk about that.
We'll have it on
so that is just to give you an impression that this is a condition that you can't joke with. And once you have it, if you play with it, it will wreck your life. You can't joke with diabetes because it affects so many different organs in the body, from the head to the toe. Once you have it, if you don't manage it well, it's disastrous. It can be disastrous, yes. Yeah. And it will cut your life short. The good news is that, like somebody was asking, can I beat diabetes? The answer is yes. You can beat it.
You can beat it.
Yeah. It doesn't mean that it's cured completely. But the sugar levels can normalize to the point where you don't need any medication at all.
Right.
Yeah.
That's great to hear.
It is.
There are people joining you online like they usually do. Thank you all so much. All this is coming to you by courtesy of World Remit and through Omega Live Multimedia. We are live on Facebook and YouTube. And if you haven't shared with your friends and family, if you haven't started your watch parties and all, please do keep sharing. I need you to do that for me. And the good news is very soon, Let's Talk About Health is going terrestrial as well. You'll be watching it on one of the Sky channels in the UK. So it tells you that we are together doing an amazing job for us to get to that extent. So well done to all of you who are watching us. So let's shoot and go on to a few people asking a whole lot of questions. I'll acknowledge some of you: Lydia Kwashi, Evelyn Esiedu, Adelaide also Achem, Stephen Tufo, Eunice Hagan, and Patricia Esilfi Ado, Joyce Mantiel. Now, I need you to bring me all the questions, and Dr. Khan, there are a few of them here, so we will look at them straight away.
Okay.
Whilst we wait for the others before we jump into the management of diabetes. But Lydia Kwashi is saying, can insulin be given to a patient whose blood sugar, obviously on the monitor, is showing a level of between, say, 9 to 12 millimoles, or either 15 to 20 millimoles, who has had nothing to eat in the morning? They've had nothing to eat in the morning and is still reading this high. Says, can insulin? I think
so. I would presume that this person is on insulin.
It is not very clear.
That's right.
Whether the person is on insulin.
That's judging from the question. I think the person is on insulin, and the person would normally test their blood sugar in the morning, what we call the pre-breakfast sugar levels, and before they have breakfast.
Yeah.
Now, if you've not had your insulin at all, but your sugar levels are above 9. You see, it's difficult for me to make that judgment. Normally, what I tend to do, I ask my patients to do some readings for me to even adjust the insulin. I would ask them to do the pre-breakfast readings, maybe for about, say, 4 or 5 days. Do the pre-lunch one for me, do the evening ones for me, and then I'll use that to tweak the insulin doses.
I'll probably rephrase their question to say, if out of nowhere I haven't been on insulin, and I happen to check my blood sugar, say a day, 2 days, and it's reading levels above, say, 9 millimoles, will I be heading towards the direction of?
No, not at all. If that is what the person means, if you've been checking, I don't know. One, is the person already a diabetic and not on medication at all? Okay. If the person knows that they are diabetic already and they've been checking the blood sugar levels, just having blood sugar levels, say 15 or 16 or 17, doesn't mean you go on insulin. It is where, for example, you've been on, and when we come to the management, you would know. Normally, we would start with maybe one medication, let's say metformin.
Yeah.
The person would be on one medication. If they are diligently taking that medication and we hit the maximum dose of that first medication and it's still not controlling the blood sugar, then we'll add a second agent to it. Okay, say you start metformin. The person is taking the maximum dose of metformin, but sugar levels are still high in their teens, in their 20s, then we'll add a second agent. If the second agent cannot control it, we have newer agents, which are tablets, not insulin, that you can add to it. Okay. If it's still not managing, then we start thinking about the insulins. Normally, it takes quite a while to progress from the point of diagnosis to the point where they need insulin. It may take quite a while, unless at diagnosis, the person had already probably had developed it without knowing for many years. So they present at first presentation with already developing what we call complications already. In which case you would look at the level of the, say somebody comes with 29, 30, 31, 32, and they have what we call end organ manifestations. So already they are having blurred vision, developing cataracts, developing retinopathy, they are developing maybe problems with the heart, they're developing maybe kidney problems, for example, already. Then it is safer for them to be on insulin rather than to go on tablet. There are so many factors we consider before we put the person on medication. So just this, it's so vague that it's difficult to answer.
And I think that will be clear to them because you need the whole clinical picture to make a decision how long all this has been going on for. So just basing it, because obviously we know that when people have, say, an infection, for instance, there is a tendency for your blood sugar levels to
go up.
You see, so
and then once you treat the infection, it goes down.
Normalize again.
That's right.
Plus, all you've had the previous day and all that. So there is more history, and that's why history taking in the management of any condition is absolutely important. So I hope we've answered your question, Lydia Kwashi. And there is another question here from Evelyn Asiedu who says, what about diabetes insipidus? Because I think we mentioned about the types of diabetes and we didn't mention about diabetes insipidus.
We were talking about what we've been talking about is diabetes mellitus. Diabetes insipidus has nothing to do with sugar. That is a different condition on its own. That is not. Why the terminology diabetes is even used. That's right. Yes.
It's always confusing.
It's always confusing. But it's not a type of diabetes. No.
I think that's got more to do with chemical things going on. So, Evelyn, that is not really directly like diabetes as in blood sugar control stuff. Adelaide Owusu-Achem is saying most people I know are on metformin. Is this the most effective drug for black people? Now that's a good question actually, or better managed with combined drugs? Because like in heart condition, we were saying amlodipine.
Amlodipine, yes, that's right.
For a drug of choice. I know she follows this program religiously, so that's a very good question.
No, metformin is given to any patient, irrespective of ethnicity. It tends to be what we call drug of first choice when we're managing type 2 diabetes. Again, when we come to management, deciding whatever medication we decide on, it depends on so many different factors. It depends on, maybe I'll explain that when we come to the management. But one, to answer her question, metformin can be given to anybody. The reason we like metformin in type 2 diabetes is that it helps with weight loss. You will remember that in patients with, say, polycystic ovarian disease, where they start developing, they start gaining weight unusually, and that tends to affect their fertility as well. We put the patients on metformin to help lose the weight. A lot of the women think that, it is being given to them so that they can conceive. The whole idea is to bring the weight down because of the polycystic ovarian disease, and then to make the cells more sensitive to the hormones in the body. That's right.
Yeah, good point.
Yeah.
Yeah. So I think that I hope you are clear, Adelaide, but that was a very good question. Stephen Tufor says, host is looking great. Thank you. He's one of the presenters here. I think he's a fan. So he's always saying that. Eunice Hagan, well done, Dr. Khan and Mrs. Ohinekisi. Great topic. I am gaining more insight. Fabulous. So keep sharing. Evelyn Kwenu, thank you for talking about this topic. Yeah, it's great. It's all coming to you by Omega Live TV, but please make sure you keep sharing. And Lydia says very interesting. Joy says very educative. Yeah, just keep sharing. And let's get all the questions to Dr. Khan whilst he's here. So, Dr. Khan, can we start looking at the management, but probably with prevention, for instance?
We've not gone to symptoms.
We haven't. But we've been touching on it as we went
that's
along,
right.
Isn't it? But do you want to do that first?
Yes, because that is. How does somebody know that they have symptoms? Okay, now. Majority of adults would realize that when you go to bed at night, normally you wake up. How many times do you wake up to pass urine? Usually none, unless maybe you've had some kind of fancy beverage. You see, very viscous Milo with a lot of sugar in there
to aid your sleep, obviously.
To aid your sleep, yes. Or maybe you've had quite a bit of fluid to drink or alcohol, and then you might wake up a couple of times at night. In the great majority of cases, most of us don't wake up at night to pee. Now, because the body is not managing the glucose load properly in diabetes, if somebody is developing diabetes, you've got a sugar load sitting in the blood. Now, we have a cliche, a term, something we say, whenever sugar moves, water moves with it.
Okay.
Whenever so if you've got a lot of sugar in the blood, think about it this way. One of the dangers is that it would drain fluid from the cells into the blood by osmosis. Simple osmosis.
Yeah.
So because of the presence of that sugar in the blood, the person pees quite a lot because the kidneys would have to get rid of that excess sugar.
Yeah.
And with that excess sugar, you need fluid to go with it. And this explains the symptom. The person is peeing quite a lot. So the person says that, oh, these days I'm waking up at night. I don't drink much, but I'm peeing a lot. Especially at night, I'm waking up 3 times, 4 times. I feel thirsty. My mouth is dry all the time.
Yeah.
Simply because you're losing fluid. Are you with me?
Yeah.
So you feel dry in the mouth. You feel like sipping water, drinking water all the time. Also, remember that you need glucose for energy. So if you're not getting the glucose into the cells, as in diabetes, then you're going to lack energy. So one of the commonest things is, I feel fatigued all the time. I feel tired all the time. I do something very little and I'm tired. I feel wiped out. A lot of times if an adult comes to me and they mention that, one of the things I always test will be to screen for diabetes. As we grow older. And previously we'll say that health checks at 40 years. Now I've even lowered the cutoff point if the person presents with symptoms. So they feel thirsty a lot, which we call polydipsia. They are peeing quite a lot, even though they are not drinking enough. That's polyuria. They are waking up at night, peeing a bit more than necessary. He's not had any beer, she's not had any beer, she's not had any beverage, she's not drank a lot of fluids before going to bed, and yet she's waking up 3 times, 4 times, sometimes even with incontinence as well. And then because, especially in women, because the sugar is leaking out, they tend to find out that they are developing a lot of thrush. And a lot of UTI because you've got sugar dripping into the front passage and that creates an environment. The front passage is meant to be acidic. So it becomes diluted and makes the woman prone to urine infections and to thrush. So maybe you're not feeling thirsty, you're not losing weight, you're not feeling fatigued, but you realize that you're getting a lot of thrush for no reason at all. It may be worthwhile just to have it checked. Or you're getting, every now and then you're popping into the supermarket buying medication to treat cystitis. I'm getting a lot of cystitis these days. Check with the doctor. There's a reason why you're peeing quite a lot. There's a reason you're having frequency of urination quite a lot. It may be that you're developing diabetes. Losing weight for no reason at all, even though you're eating normally. In some patients, as even though a great majority of type 2 diabetics, would present as being obese or overweight. We also have a group of patients who would rather present with weight loss. Those are the ones that sometimes you test the urine, you see ketones. Yes.
Two extremes.
The two extremes. You would test the urine and you realize that even though he's an adult, but he's developed maybe late onset type 1 diabetes, and they may need insulin right from the word go.
Yeah.
So we've talked about either weight gain or weight loss. We've talked about feeling thirsty, unusual. We've talked about peeing quite a lot, thrush, lack of energy, fatigue. All these things are symptoms of. It gives you a picture that a person may be developing diabetes.
Yeah. I mean, whatever happens, we often at night is not. It's not good, and the reason why you need to be checked out, because especially like for the men, it could be a sign of prostate cancer as well. So either way, there will be something that is not quite right that needs looking into. And I know a few,
unfortunately, we have all kinds of beliefs because of our maybe cultural background. Cultural background. We have all kinds of beliefs. People take all kinds of medications and concoctions and whatever. We have so many medications back home that claim to cure every kind of disease.
Can it be cured?
Can diabetes be cured? Diabetes can be cured.
Right.
There's a lot of evidence coming out that with good lifestyle modification, it can.
Right. And the medications that they are talking about, can it be cured?
Oh, which one? You mean the herbal preparations?
Exactly.
I reserve my comments. I don't want. I don't want any contentions.
Everything, isn't it?
How is that possible that one drug cures everything? It is not. It doesn't.
And we are only giving stuff that is evidence based. So without that, we cannot really.
No, I cannot comment on that. Not at all.
Adelaide Owusu-Achem is saying, I hear some men don't like to take the medications as it affects their libido. Any thoughts on that? Is that true?
It is not the medication per se. When we come to complications, you will realize that diabetes affects the small blood vessels and the small nerves.
Yeah.
And the blood vessels that supply the penis. And a lot of men with diabetes develop erectile dysfunction.
Okay.
That's the reason. Diabetes causes erectile dysfunction.
Okay.
That is why in a great majority of our male diabetic patients, we put them on sildenafil or Viagra just to help it. Yeah.
I see.
But unfortunately, sometimes, you see, once you've developed diabetes, remember I said it affects so many organs. The person starts on one medication. Because the disease is progressive, if you don't manage it well, within 5 years, it is getting worse already. So you end up from one medication to 2 medications to 3 medications. And then the blood pressure, because it affects the cardiovascular system. It affects the blood vessels. So you see the blood pressure also starts going up. So you end up on blood pressure medication. A medication like Ramipril, for example, affects the libido.
Okay.
Yeah. Lisinopril will affect the libido. Losartan has a way of affecting. A number of the blood pressure medications would also affect the libido.
Yeah. So it's more to do with the condition itself rather than the
metformin.
Okay.
Yeah.
So which other stage do you want us to consider, like in the management? We've looked at all the
yes, that's right.
And symptoms and
so
stuff.
once we've made a diagnosis, so the person comes and you test the urine, the sugar in it, then you request a fasting blood test. Normally we'll tell you to fast overnight for 12 hours, whether 8 to 8 or 9 to 9 in the morning, and then you have the test done. If it comes and it shows that you've been diagnosed with diabetes, we bring you in. Is it everybody who needs medication? No. So let's say the person is in their 40s, very active. You know that the diet is reasonably healthy. Okay, they have the discipline, for example, to lose weight, the discipline to step up, increased activity. If let's say it came in and it's just above normal and the person is quite young, I may not necessarily start them on medication straight away.
At all.
It would also depend. I would look at, once you've done the blood test, we will do your renal function, kidney function. So we'll look at the kidney function. How good is it? If it's good, you know that you can give most of the medications safely. If the kidney function is affected, you have to be careful. For example, if somebody's kidney function is low, you be careful giving, say, metformin or glycoside because it can be toxic to the kidney. There are medications that can affect the kidney. So you look at one, the age. 2, do they have other medical conditions? 3, at the stage of diagnosis, have they already started developing complications? So, for example, some patients may not have all the symptoms that I spoke about, but one of the things they realize that I didn't mention is visual disturbance. So the person says, my vision is a bit blurry. My vision is becoming blurry. Then they go to see the optician. This is how we pick up many of the cases as well. He goes to see the optician. The optician says that there's no problem with the refraction or the reading per se, but the problem is that you are developing cataracts, which have started slowly, that the person has not even noticed. At night, vision becomes very blurry, or the optician looks at the back of the eye, the retina, and starts seeing changes. Sometimes maybe stage 1 retinopathy, sometimes stage 2 is progressing, and then the next thing that optician says is that you need to go and see your GP to screen you for diabetes because he's seeing something there. If the person is already developing eye complications, maybe, and then at the same time the kidney function for his or her age has also dropped significantly, maybe they have high blood pressure, and then they've developed diabetes, even if it's not great, they've already started developing symptoms. In that case, I'll advise them that, look, I don't want to delay treatment. You may want to have lifestyle modification and all that, but you're already developing organ damage. So if we don't treat, it will just progress within a few years. So in that case, I would start you on medication. But if they don't have any organ damage, they are fit, they are well, they are young, they have the discipline to change their diet. Not everybody has the discipline to change their diet, including me. It's not easy. We love our food.
It's very difficult to do that.
It is difficult. And
so in terms of like hypertension, for instance, like an eye check, we said there can be an accidental finding through your eye check, for instance, just because the blood pressure in the eye goes up as well. But in terms of diabetes, it's just structural kind of changes.
Structural changes, just like in hypertension. So in hypertension, you realize we talk about hypertensive retinopathy. It also affects the back of the eye, just the same as diabetes as well. Remember, both of them are affecting small vessels. Okay, you're a cardiac nurse. You know the small vessels, the capillary the arterioles. Those are the things that hypertension will damage, and diabetes will damage, and it makes it harder with time. So you look at the back of the eye and you see the changes already developing. And at the same time, you'd be surprised that you do the person's lipid profile, and you realize that their cholesterol levels are high and other parameters are high. As well.
So in terms of diagnosis, is it just by urine test and blood test?
Those are the basic ones we do initially, unless we need to do other tests to establish whether is it type 1, is it type 2. Sometimes some of them are borderline, in which case then you refer them to further blood tests, just to get the precise
especially
diagnosis.
Because of the question Lydia asked about how much the blood sugar level should be after fasting and checking her blood sugar. What are the normal ranges we are talking about? Like if people are checking, because the last time we did hypertension, the number of people who said, I bought a blood pressure machine.
Beautiful. That's what I like to hear.
So many people, which was encouraging. Do we need to own a blood sugar monitor? And if we do, what are the normal ranges we are talking about?
No. Even in type 2.
It's not so necessary for this one, is it?
Even in type 2, you know, when people are diagnosed, people think that, years ago, we used to stick a glucose monitor for every patient to take home and check their blood sugar. Now for type 2, we don't do that anymore. Type 2 tends to be much stable. You don't have a lot of fluctuation in the blood sugars, unless the person is not compliant with medication. Look, a number of our patients will come, the blood sugar levels are high. They'll tell you that, I'm not eating. I've cut down my... I had a patient like that. For months, I was struggling to manage. We insulin this and whatever. It was the patient's son who told me, are you aware that mommy is guzzling every evening? She'll have this and have that and have cookies and have this. I said, no. She says that she doesn't have anything at home. I said, no. Mommy has this stuff at home that she eats every night. And that explained to me at that time why her early morning blood sugars were quite high. So then we had to have a conversation that, look, I can appreciate that these are things you like. Are you with me? But it's affecting your blood sugar management. So in terms of the management itself, as I said, discipline, the ability to manage the diet is key.
Yeah.
If the person cannot manage the diet, then I would think, okay, what can I give to the person to help them manage their diabetes? I would also look at compliance, for example. Some people are so busy. Let's say the person is, say, a driver who is on the road all the time. It will be difficult to put the person on insulin. Insulin will be a last resort because they have to regularly check their blood sugar. Are you with me?
Yeah.
Not everybody needs to have a monitor with type 2 diabetes. So I wouldn't recommend that people should just go and buy a monitor at home and start testing their blood sugar.
Yeah, because especially
finger prick, finger prick only gives you an impression, but it's not diagnostic, for the simple reason that maybe you've picked a fruit, you've picked cake, you've picked a sweet, you've picked something, but you've not really washed.
Yeah, because people don't generally wash their hands.
People don't generally wash their hands, and then she does the test,
Yeah.
and when she did the test, it showed a high level of blood sugar, but she's forgotten that she's just picked up some sweets or picked up something.
That's there for you to
Yeah.
make sure your hands are washed
before
before you do a blood sugar check.
blood sugar test.
Yeah.
If the person is diabetic already, again, you see, this is why I'm not going to give people the range, because the range we give you is tailored to the individual. If I have a patient who is 70 years of age with other comorbidities and other medications, I'm not going to aggressively lower the blood sugar level to say below 6 in the morning. That could be a recipe for disaster, because then if I'm not careful, overnight they could develop hypoglycemia. The sugar levels can drop, and then they start developing other complications as well. So I tailor the range to the specific individual. It depends on how well the diabetes is controlled, the age, other comorbidities, the medications that they're on. Okay, but in an ideal world, if you're a diabetic, early morning blood sugar level between 6 and 9 would be good to manage. If you can keep it between, if you're young, much younger, 6 to 9 is a good one. Because you realize as a diabetic that once you start dropping below 5, you start getting the shakes. You start developing, feeling sweaty, feeling like you need a sugar boost. Are you with me? You start developing features of hypoglycemia.
And they are one of the group of patients who generally know their body very well.
Yeah, that's right.
The effect, how they feel.
How they feel, but if you're persistently having values above 10, then it's a bit high. Then it means that you're not managing your diabetes quite well.
Right.
Yeah.
Oh, okay. Yeah, there's a question here from Nana Adwa. She says, what range of kidney, I think, as function is normal to give medication? I think it's quite a vague question. I'm not quite sure.
It's, I think, you know, a lot of patients would go and see their GP when the kidney functions are done. There's a term we use called EGFR. Now people are being told that, oh, you've got CKD1, CKD2, CKD3, or chronic kidney disease. I remember a while ago when we started using this classification, my mom went to discuss her kidney parameters with the GP. And then when I called her, she said, oh, she's been told she's got kidney disease. And I said, why? So I got hold of the results, and I had to explain to her that it's just a classification we use. And the classification allows us to then monitor whether somebody's kidney function is going low or not. So I'll give you an example. So for example, we would say that anybody would say EGFR, which is how the kidney filters fluid. Okay, it's too technical to even explain it.
Yeah, it is.
Then we'll say that if it's above a certain value, say 59 and above, we'll classify you as within the normal range. Are you with me? And if it's also between, say, below 59, we would come all the way down to say 40, a range of say 40 to 59. We would give it a classification. A range of say 30 to 40, we give it a classification. Generally speaking, if the value is below 30, then it's getting too low.
Right.
At that point, if your EGFR, or the rate at which the kidney filters, is 30 or below, we start stopping metformin.
Right.
We'll stop glycoside.
Okay.
We'll put you on medications that are safer for the kidneys.
And all these are things that you probably don't have a hang of managing yourself.
No,
you need
these are things you need to discuss it with your GP. It is why every year as a diabetic we would do blood tests regularly. Sometimes if the person comes, maybe last year we check the kidney function, they come in this year, I see a sharp drop in the kidney function. I'll repeat it again. So maybe say in a month's time, tell the person that drink a bit more fluid and then do the test first thing in the morning just to see how the kidneys are functioning, because that's key to managing the diabetes, whatever medication that we prescribe. So in terms of management, not everybody may require medication right at the onset. If they come in, it's borderline, then we have a hard talk. Okay, you need to, is it everybody who has diabetes who is overweight? No. There are people who are skinny,
and
who've been diagnosed with type 2 diabetes. Okay, but a great majority, 80 to 90%, tend to be overweight. The amazing thing is that if they manage to lose the weight, you see the sugar level drop. It just drops because you're dealing with carbs, carbohydrates. And that is one of the hardest things for people to drop from the diet. I'll give you an example. I tried one of these ketogenic diets. I said I needed to get rid of my family pack. So I started taking, eating, these salads. I'm an African man eating salads. So it's not easy. Within the space of 1.5 to 2 hours, you're hungry. Because there's not much carbohydrate in there, and carbohydrate supplies energy. So if you cut out the carbs, you see that very soon you start getting the shakes. And this is where people struggle, because he's used to 2 big bowls of fufu or 2 big balls of gan kenke, are you with me, or fanti kenke, boxed up with a lot of meat and soup and whatever. So the calories going in is quite high. So the person comes in, you tell the person that, well, in the morning, your breakfast alone is about 1,000 calories. Your lunch alone is more than 1,000 calories. Your dinner, dear, more than 2,000 calories, because you wash it down with Coke or boxed drink that we love so much. Are you with me? All this adds up. The sugars that are going in.
Very high content.
Very high content. So if you ask the person to suddenly drop this, it's hard.
The body is going to be sending you signal.
The body would send you signal. So I tend to do it a bit more slowly. I know habits are difficult to shake off, but you have to also explain to the patient in no uncertain terms that, look, this is the danger of the condition that you're dealing with. If you don't manage it well, the condition can kill you. So you've got a choice. Either you drop those nice things that you love to eat, or it will damage your eyes, your heart, your kidneys, give you impotence, cause you stroke, heart attacks, other things.
There are a number of questions here from
let's go through them.
Who are joining in. Harriet Apia Anderson, very informative. How I wish I could use that for revalidation. I think you can. It's just one of our nursing 3-year assessments we have to do. But you need information to back it. So I'll look into it if we can have some material so they can say download it and reflect on it. So they use it. But
that'd be great, isn't it?
Why not? Because it is a source of education to you. So
people are doing webinars and whatever, and the webinars qualify for CPDs.
Exactly. So I think you can reflect on it and use it. So let me take a question from Daniela Pritchard. She's saying some take STC30. I'm not quite sure what that is. Which you put under your tongue and it dissolves and it's meant to reduce your sugar level. Is that true?
I don't know what.
A lot of Daniela, you will have to let me know what exactly STC30 is because I haven't heard of that before.
That's right.
I've seen a lot of patients doing this, which are mainly the Africans. Oh wow. I have never come across this one, Daniela.
I've not come across it unless it's a brand name for a generic product that we use. But again, I can look into that.
Daniela, give us a bit more information. You are a nurse as well, Daniela. Find out a little bit more.
There are novel treatments that are coming up. And most of the treatments, in this country, most of the things we prescribe have to be endorsed by National Institute of Clinical Excellence, NICE. So it's difficult. Sometimes a novel treatment may pop up from, say, US or part of Europe. We're usually one of the slowest countries to adopt.
Eventually
start using medication because we tend to have stricter monitoring and guidelines over here.
Yeah, and apparently these STC 30 are about £150 for only 15 days worth.
So people are buying it over the counter then?
Probably, yeah. So give us a bit more information.
That's right.
Dr. Khan, how do we treat diabetes in children? And then there is another question from Letitia Arthur, who is watching from Ghana. Hi, Letitia. And she says, is brown sugar diabetic friendly? Brown sugar. Sugar is sugar.
Okay. Yes, sugar is sugar, but brown sugar is unrefined sugar. So in a way, you say it's diabetic friendly. But sugar is sugar. Okay.
Yeah.
The white sugar usually is
refined.
It's refined, and that is the one that we try to encourage people to avoid. Now, instead of, if you're a diabetic, instead of using sugar, okay, probably try honey.
Yeah.
The reason being that honey has more of fructose.
Yeah, the natural one would be better, isn't it?
Yeah, that's right.
Because apparently these days they are mixing it with all sorts of
And
stuff,
the thing with honey is that the sugar in it is unrefined and it's slow. It's slowly absorbed into the body and it works over a period of time. So instead of using proper sugar, you can use maybe a teaspoonful of honey.
Yeah.
Honey. And then slowly educate your tongue to dislike a lot of sugar.
Right.
Yeah.
Okay. So more questions coming in.
Yeah.
But Dr. Khan, I want you to start looking at if we could prevent all this from happening and manage ourselves very well, we'll probably not get to the worst stages of diabetes.
Yeah.
So think about like starting how we can manage it. But in the meantime, I have a gentleman here, Kela, saying, does maintaining an alkaline pH in your system than acidic pH helps with diabetes? You must be a technical person to be asking this, because I mean we don't maintain alkaline.
I'm trying to understand where he's coming from, in the sense that diabetes, one of the things you don't want, if you don't manage it well, people tend to start developing what we call acidosis, metabolic acidosis.
Yeah.
That's probably where this alkaline pH is coming from, because if you have acid, you want to neutralize the acid with some alkaline to make it neutral. If somebody is going to develop acidosis, it depends on, one, the type of diabetes they have. You tend to find acidosis in type 1 rather than type 2. Are they starving themselves? Are they complying with medications? And again, what is the state of the kidney? The kidney is so important when it comes to diabetes management and even the complications, and the kidney is quite key. What is the state of their kidney? It comes down to all these little bits. And what kind of foods are they eating? Are you with me?
Yeah.
People used to be of the view that, if you're diabetic, you can't eat a lot of things. No. The whole idea is not about what you cannot eat. It's about portions. It is all about portions. And it's all about carbohydrate counting. The amount of carbohydrate that goes in. Remember that carbohydrate is broken down to glucose quickly to release energy, compared to, say, protein, compared to, say, fat. And that is the basis of all these diets that people do to lose weight. To lose weight is that the more carbs you have, the more you lay down glucose. And any excess glucose in a grown-up will be converted to glycogen, converted to other stored forms.
Yeah. Right.
Of
So,
sugar,
with regards to the STC 30, I've got Charles Quays. Hello, Charles. He is a nurse as well, and I think he's looked into it.
Excellent.
And sent us
Give me some information.
Says,
Let me just.
It's called Super Life Total Care 30.
Okay.
And it regenerates and repairs damaged cells.
I've just
tissues and organs
you see
of the body.
Yeah.
And it also goes on to say, by activating the stem cells in your body,
that is what it says here.
Receive signals from the brain and goes to repair every damaged blood cell or vessel.
So for something like this, sometimes I refrain to comment because I've not read the evidence about it.
Yeah.
There are so many supplements and things out there that are of proven benefit. So normally, if I've not read about something, I don't want to make a comment, because you see, on air, then people start going to buy the stuff. Sometimes you do have a patient who buys a product, and then we'll give you a call. is this safe for me to take? And I tell them that no, I cannot make that comment because
yeah.
the person has bought it in the first place. They just want your endorsement to go ahead and use it. But sometimes you don't even have an idea what state of a kidney do they have. I always tell people that before you start using a product, please speak to your GP. Not everything will be safe for you. Don't start using medications when you've not even tested your kidney. Your kidney, your liver are like the detoxification centers.
Yeah.
Any chemical that goes into your body, they have to be able to manage it. If your kidney is not working, you might end up damaging.
And I always say this because we had pharmacists here, and everyone always, all the professionals say is, be on the side of caution.
Act on the side
they consider the whole clinical picture before they advise you to do this or to do that. So when it comes to supplements, it's a tricky one to do.
Now, I think what sometimes disturbs me is that people feel that, I don't have the time to go for a checkup. Okay? But they would spend hundreds of pounds buying every medication under the sun.
Yeah.
And my question is, the blood test is free. Just a blood test is free.
At least in the UK here, isn't it?
Yeah. Why can't you find the time in all your busyness, just an hour to go to the clinic and check your health, which is more important to you? So if somebody tells me that, I can't even find an hour in a whole year to visit a doctor or a nurse to have a checkup, then you're indeed busy, very busy. And if you're not careful, that will be your undoing. What is the essence of all this money? And then you have to then now spend the money on trying to reverse something you could have managed.
I think time is going now.
So let's look at prevention, isn't it?
Yeah.
It comes down basically two things: managing your diet well, weight loss, activity. That's the key. That's all. And in terms of diet, we know how the Afro-Caribbean diet is. It is carb-based. That's our staple diet. It's through no fault of ours. We eat a lot of yam, a lot of plantain, a lot of cassava, rice, and the portions that we eat normally is quite a lot. There's nothing like small portions. I was showing you the app, the Caps and Carls app, that you take one fried egg and 115 calories. 2 fried eggs. How many of us eat just one egg? We don't eat an egg because it looks too small. You eat 2, and it's not just the egg. You add maybe 2 thick sliced bread. You see, you box the egg inside, and it's not just the egg. It's an omelette. It's not plain egg.
With corned beef and everything. As well.
Corned beef and green pepper and
fully loaded.
And then your beverage is sitting by it. That's breakfast. And then when it comes to lunch, when I go to work, my colleagues are eating sandwiches in the afternoon. Sandwiches. Thin sandwich with maybe a slice of ham in there. And if I look at my lunch and I look at their lunch, there's a difference. Yeah. There is a difference. Mine is, I don't want to go through what I eat for lunch, but by courtesy of my culture, my background and whatever, it is loaded. And then when you come home again, you have to also eat dinner. Cast your mind back home. Breakfast is watchy with all kinds of things. Then lunch, it's a whole package. And then dinner. And in between, you drink minerals. With me, if you can afford it. We live a good life, but that good life is dangerous. So instead of having 2 bowls of kinky, reduce it to 1. Just 1, and add more greens to it.
Start by cutting.
You start by cutting down. We don't say don't eat it. Start by cutting. And instead of maybe having a dessert, which is a slice of cake, take the cake out. 1 small or half a bowl of kinky or 1 bowl of kinky with quite a bit of veg. Are you with me? Quite a bit of veg. That's healthier. And then slowly you would see the weight start coming off. If you can cut out just the carbs, I'm not even talking about the meat or the soup. That is a subject for another day when we talk about diet and nutrition. But I'm talking about just the carbs alone. I've seen patients lose significant amount of weight just by cutting out the carbs. All they did was cut out the sugar, cut out the quantities, the cakes, the confectionaries, the sweets, take the sugar out of the tea, drink maybe less cups of tea in a day, cut out that beverage that you drink at night before you go. And it's not just the beverage, it goes with maybe 6 or 7 digestive biscuits or crackers or something. All of it is carbs. It adds to it. If you start cutting it down, you realize that in a day, you're cutting out more than 500 to 600 calories in a day. And in no time, you would see the weight start coming down slowly, slowly. And this is the key to actually managing the condition. When patients have cut down the carbs, over a period of about 3 months, when they come back, we check, it's amazing. You see the blood sugar level goes down. So even if you started them on medication, now they don't need to take morning and evening. You tell them that, oh, your sugar level has dropped significantly. We reduce the dose to say 1. Then you check it again after 3 months. Weight has gone down. They are walking a bit more, driving less, taking public transport if they can, or walking to work, walking to supermarkets, doing local walking. They calm down, they feel fitter, they feel stronger, the weight has gone down, diabetes is improved. Now the good news is that, and we'll come to complications shortly before we round up, it also starts improving. You see the complications that you were developing start improving amazingly. That's the thing with type 2 diabetes, that you can beat it actually. You can, unless it's progressed to the point where it's irreversible. But if you can manage right from the word go, manage the diet, manage the weight, then it is something that you can manage.
There is this term we hear a lot, BMI, body mass index, in the management of almost everything. Where does that come into play? What do people need to know about this BMI thing?
Body mass index, basically, it is helping us to manage our weight properly. Okay, so you take the weight. So you check the person's weight in kilograms, and then you divide that weight, you know, the height. So if, for example, my height is, say, 1.7 meters, okay, we normally use centimeters or meters, okay? Okay, if you put the chart there before we come to the complication, Yep, so this is a typical body mass index chart. So you take the person's height, which is measured in centimeters. So let's say if I'm, say, 5'10", okay? In centimeters, that would be 177.8 centimeters. Is that okay? And then my weight, we'll check my weight. Let's say my weight is, say,
90 kilos.
Yes, my weight is normally around between 80, it fluctuates between 80 and 90 kilos. Let's say if I check my body mass index says maybe, say, 29. If I come to 29, where is the height? Here, okay? 29 here. You see, it falls within what? The yellow. Yellow means that I'm overweight. Okay. Now, normally when we deal with body mass index, we check your weight, then we check your height, then we use a calculator to calculate. The value that it gives us, if it's between 18 and 24, normally if it's below 18, you're malnourished, basically. There's a problem. Between 18 and 24,
those in the blue.
Those in the blue, you see that all the ones below, it says underweight. And then between
the green,
18, that's right, 19 and 24, we say healthy, within the green band. And then you go to 25 to 30, we say you're overweight. Above 30, we say you're obese. And in the red zone, we call it extremely obese. We check the body mass index. Once we've done your lipid profile, we've done other parameters, then we'll calculate something called cardiovascular risk, which is your risk of developing a heart problem or a stroke, for example, in, say, 10 years. That is what all these values allows us to do. So we'll look at your lifestyle, your age, your lipid profile, your kidney function, so many different things. And whether you've got high blood pressure, you've got diabetes, every one of them will give you a score. A score. That's right. The one thing with BMI is that sometimes you can have a solid rugby playing guy, muscular, who is, say, 120 kilos. But because of the height, you might think that the person is obese based on the BMI, but they are solid muscle, not fat. So if the person is obese, but it's fat, then that's dangerous. But they can be muscular and still have a high body mass index, but
I
they
think
are
that's
fit.
the only discrepancy with
That's the only discrepancy with it, but it's a
BMI
very good indicator. In terms of your weight and your risk.
And just to add on, just for the purpose of this conversation, the BMI is also a guide that we use, especially in the acute setting, like in nursing, a lot of nursing assessments. So, for instance, if anyone comes on admission and obviously you are bedbound for a while, or there is an assessment that we do and the Waterloo score to check how much at risk of pressure ulcer,
that's right.
for instance, you are. And again, we use that in false assessments, because obviously those who are heavy will struggle to move or mobilize a bit more. So these two, or knowing your body mass index, is also very good, and we use it in the acute setting a lot to determine how safe or unsafe, and determine how, like somebody would be at risk of say pressure ulcer, for instance. So for instance, if an elderly person comes, these assessments take into account, say, your age, how active you are, and a whole lot of other factors combined. And then the higher the score, then the more at risk you will be at developing, say, a pressure ulcer. I like these to come out because sometimes we have our parents back home who are being looked after by other people, and sometimes they'll be there and all you hear is they've developed, say, a pressure ulcer. It's because we are not looking at all these kind of assessments that come into play. So I think at another time I will probably look at how to look after your elderly patients, especially back home, because we don't have nursing homes. All this is all hospital or home, isn't it? So one day I think we will probably look into that. But just to add on to the BMI, the usefulness of knowing the BMI.
So just quickly, let me just mention in terms of management. We either will not put you on any medication, or we can put you on tablets. It depends on how you present it.
So we are in the management now.
Or insulin, for example. But in type 2, we don't tend to normally use insulin unless we've tried everything else. But your diabetes is getting worse and worse and worse. In which case, if we don't control it aggressively, it would destroy your organs. So then we would advise that we put you on insulin. A lot of people, as soon as they hear the word insulin, I mean, they become very demoralized. And, is that where it's got to? Do I really need insulin? And then also managing the injections and their lifestyle and all that. This is where the difficulty comes in. We are blessed with so many different choices of medication. Now you can have a 1-a-day tablet, 1 twice-a-day tablet. You can even have a 1-a-week medication. So for people with very busy lifestyle, jet-setting high flyers, the person has diabetes, they don't have the time to be stopping to pop medication morning, afternoon, evening, or morning and evening. So for example, if she or he has 1 injection a week, not insulin, we have other injectables which are not insulin. So they'll just inject once a week, and it manages there. So there are so many different options that we can use. Depends on your age, your blood parameters, how bad the diabetes is, the job you do, your lifestyle, how disciplined you are, how compliant you're likely to be on medication. And then I take all these things into consideration when I'm managing a patient's diabetes, because my special interest is in diabetes anyway. So I would take all that into consideration. Some people ask that, should everybody go on metformin? No, it's not one size fits all. The treatment we use is tailored to the individual. Because if I'm a carpenter or a teacher, let's say I'm a teacher standing in the classroom the whole day, when is the time to take my medication? So in such a case, I might opt that no, I don't need to put the person on metformin. Maybe they are not obese. Maybe the person's body mass index, for example, falls into maybe say healthy, within the healthy category. So I may not necessarily need metformin, for example, because one of the reasons for metformin is to help the weight loss. Metformin is good in the sense that it's the what we call drug of first choice, and it's also reasonably priced. So we have to look at the financial health of the NHS as well. So we would always opt for metformin, all things being equal. But if I look at all the factors, some people would, for example, not tolerate metformin. Metformin can cause nausea. It can cause gastric symptoms. So they'll come back and say that, no, I feel sick all the time on metformin. In which case, then we might give you either the modified release or stop it completely and then give you something different, which is suitable to your lifestyle. Sometimes the person comes and you see the blood sugar is not well controlled at all. They'll tell you that, no, I don't have the time to take the medication. Is there a choice? I can change it to a 1 a day newer medication that controls the blood sugar. So there are options to use. It all depends on the state you're in at diagnosis, basically.
Yeah, I think we wouldn't be doing a good job if we don't look at some of the complications.
The complications are quite important,
can happen. So if we can have that projected onto the
slide,
so we look into the complications. Whilst we are waiting for that, I have Kwesi Alex, Philo Desech Akita, Daniela Pritchard says diet is important. Abnanya Akua, this is very, very educational. Thank you. Francis Achampon is also watching, said Grave Samson, Beatrice Asante, Beatrice Edu, Joyce Mantiel, Papa Kujo. They are all saying very informative and saying thank you as well for a great show. Keep sharing. All this is coming to you by courtesy of Omega Live TV.
This slide was the one that was talking about how the glucose enters into
the cell.
Into the cell. You have the pancreas that releases insulin. The insulin opens up the cell so the glucose enters. When the beta cells are destroyed, as in type 1, there's no insulin coming in. The receptor is there, but there's no insulin allowing the sugar to go in. And then in type 2, the insulin is being produced. It gets to the cell, but for some reason, it's not entering the cell. So the person has insulin, so you need a medication. So there's insulin resistance. You need another medication to help reduce the weight and to help the insulin enter, allow the glucose to enter the cell. When you come to complication, always remember diabetes essentially would affect either the big vessels as well as the small vessels. So we use the term macrovascular and microvascular. It also affects the nerves, big nerves and small nerves. It can affect a particular group of nerve or multiple nerves. So a lot of times patients will hear the term neuropathy. Neuropathy just means neuro means nerves, pathy means disease, a disease of the nerves. So you can have just polyneuropathy, which means that it is affecting several nerves. And because of the high levels of sugar that I mentioned right from the word go, that glucose must be maintained within a particular range to allow the body to safely, the body cells, to live within a safe environment. Are you with me? If you don't manage that, then any excess glucose or the absence of even glucose entering the cell can cause damage to the body. Excess glucose or poor diabetes control has a way of damaging the small vessels and damaging the nerves. So I'll start from the top. Diabetes makes you at risk of strokes. That's one of the things. So if we start from the brain, and in some cases, even dementia, long term, it can lead to dementia as well. So that's right. So it affects the brain from the top. Then you come down to the eye. If you come down to the eye, which we've already alluded to, that it causes cataracts. It can cause, in some cases, glaucoma, blindness. It is said that a great percentage of the cause of blindness, especially in low to middle income countries, is attributable to diabetes. So it destroys the eye simply because it's affecting the small vessels over a long period of time if it's not managed properly. And then you can see skin infection. There are other infections as a result of this poor glucose control. Skin becomes dry, it becomes itchy, it becomes very irritable, very irritable. There are particular skin conditions that are associated with diabetes. Actually, sometimes somebody comes in, you see a particular condition that affects the shin. Now you have a look at it and no, let's test.
Blood sugar is high.
And it's high. And you pick it up. That's right. So if you have any skin conditions that looks unusual, it doesn't appear to go away, but you've not bothered to check, screen for diabetes. You may not feel thirsty. You may not be losing weight.
You may not have the usual
symptoms, but it's just skin infections. Then have a check. And then if you see the other one, it says atherosclerosis. Basically, atherosclerosis means hardening of the blood cells as a result of cholesterol deposit. One of the things diabetes does is that it also has a way of increasing the cholesterol, the lipids. You know, people hear bad cholesterol, good cholesterol.
Yeah.
Good cholesterol is what we call HDL, high density lipoprotein. And then bad cholesterol, LDL or triglycerides. Okay, I don't want to bore people with the terms. What cholesterol or lipids do, the danger is that, just as the last time when we did hypertension, I said that if you have a lot of fat circulating in the blood vessels, it lines it.
The vessels, yeah.
It lines the vessels, so it is almost like having a pipe or a tube with scales in it. It blocks it. Diabetes makes it worse.
Yeah.
It, in addition to the fat lining the blood vessels, it makes it hard.
Yeah.
So that instead of the blood vessel expanding properly when blood is flowing through it, it doesn't. It becomes
lose their
hard.
elasticity, isn't
That's right, they lose their elasticity, atherosclerosis. And that makes you prone to heart damage, basically. So when patients come and we say that, look, your blood glucose is poorly managed, your diabetes is poorly managed, essentially what we're saying is that if you don't manage it well, it will affect your brain, affect your eyes, affect your heart. And then you look at the kidney there. I did mention that you have 13,500 cases. I mean, kidney disease, severe kidney disease.
That's a
lot as a result of diabetes alone. Are you with me? Now, to get a kidney transplant is hard. You did, you know, the lady, somebody came in here, dialysis and whatever. We don't want people getting to the stage of needing dialysis. But I'm afraid to say that if you don't manage the diabetes well, if you don't get yourself checked up, all of a sudden you develop kidney damage, and that can be debilitating. If you're not careful, it just stops your life functioning, basically. And then you have fatty liver. One of the commonest questions, people come in, they have their liver function test done, and then sometimes you see, we say that, oh, your liver function is deranged.
Yeah.
We need to do an ultrasound. So we do an ultrasound. The ultrasound report comes back. It says that you got fatty liver. And it's not a disease per se, but it's an indicator that there must be a bit of weight loss there.
Right.
That's right. So that you can get all this fat away from the liver cells. And usually a very good diet would reduce that fatty liver. But diabetes also causes a deposition of lipids into the liver itself. And then long term, it can affect the liver.
Yeah.
And then you have osteoporosis, which is brittle bone. It's a long term complication of diabetes. For men, you would realize that if you're a man, if you don't control the diabetes well, or if you have the diagnosis but you're not aware of it, one of the things you realize is erectile dysfunction. People equate erectile dysfunction to impotence. There's a difference. You know, previously we used to use the word impotence. Impotence is the extreme form. Impotence means inability to have an erection. In the great majority of cases, there's the ability to have the erection, but the strengths are different. So, for example, the person may know that, oh, my libido is gone. And libido going doesn't mean that you're impotent. It's just your libido that is gone. The libido is the desire. With the desire, then you get the erection. But somebody may sustain it for just a minute and it goes limp. Somebody may sustain it for just 5 minutes. Somebody may sustain it for 10 minutes. So there are degrees. That's right. And that's why we use the term erectile dysfunction. Diabetes causes that. Simply because it slowly damages the small blood vessels that go to the penis, and then also the nerves that supply the penis as well. Okay. And then the final bit is the foot. It doesn't show it here.
It doesn't show. Right.
One of the most dangerous complications. Again, it is the same mechanism. It damages the small blood vessels of the foot and the nerve supplying the foot. So the person will be there. They say that I'm getting pins and needles sensation. Quite commonly, so that's chi in Ghana. Like it feels like pins and needle sensation on the foot, in the hands. Okay, that's an indication that no, the nerves are being affected. And after a while, with the pins and needle, it progresses to the person not having any feeling at all. So the person can step on a nail. They are not even aware that they've been pricked by a nail. And then with time, the next thing they come, and this is also the basis why we do foot checks. And I'll talk about that in terms of prevention quickly before we round up. So the person realized that I'm losing feeling in my foot. if they don't go for foot checks, they could even develop an ulcer.
Yeah.
Under the foot, and they are not even aware that they've developed something. The reason they can't feel the pain is that they are developing diabetic foot disease. The nerves are being destroyed, the blood vessels are being affected, so they don't have it. They don't feel any sensation.
Those are late indications.
These are late indications. If you don't take care of it, this is where people end up with amputations. All of a sudden, the nerves and the blood vessels are destroyed, and the foot, you see them developing gangrene. Gangrene, the toes are becoming black until it progresses to a point where it becomes very critical. Are you with me?
Yeah.
So when a person is diagnosed with diabetes, part of the package, and we call it the ABCD care of diabetes in this country, because we take it that seriously. Every year you will get invitations to come in. The reason we're asking you to come in, one, is to check you overall to make sure that you're not developing complications, you're complying with your medications, test your urine, do your blood test. You speak to the diabetic specialist in the clinic, and they'll go through, make sure your diet is okay, and then we'll check your foot. We do tests we call Doppler. The Doppler we do is for a reason, to check how well the blood flow is coming to the extremities. You would see the doctor or the nurse would start feeling the pulse around the feet. It is not because we just want to feel your foot. No, we're checking the blood supply that goes to the feet, just to make sure that, and then we will test it with certain things, pins and brushes and so many different things. And we'll ask you, do you feel the sensation here? Do you feel the sensation there? We'll do some vibration test as well. All of it is designed to make sure that you're not losing your nerve sensation in the foot. Some people would also realize that as the disease progresses at night, there's something we call burning feet syndrome.
Burning feet.
Burning feet. It feels as if the foot is on fire, or the feet are on fire all the time. Coupled with the numbness and pins and needle, then we know that no, the person's diabetes either is poorly controlled or they are developing complications. Then at that point we may step up the treatment, just to make sure that the complications do not progress. So all in all, from the head to the toe, it affects
everything. Yeah.
Everything.
Wow.
Yeah.
Wow. Viewers, for those of you who are just joining in, we are just about rounding off, but you can go back and watch, do all the watch parties, get your friends to get to know all that we've been discussing here. Tonight we've been looking at diabetes, how it starts, how it can be recognized, how it affects us, and why we are so vulnerable as Africans and blacks generally for having diabetes. And I've had Dr. Khan here. We are well over an hour now. Yeah, we've been going for about an hour and a half, so we'll be rounding up very soon. But you need to go back and watch and listen into it. And there are a few people who are giving us compliments here. Most of you are saying thank you very much, but I need you to be my ambassadors, you know, to be sharing, and let's keep educating people, because these informations will definitely save lives. So Barbara Boahene, Mami for Blessing, Kweku Ejenin Boateng, June Reed. June, you are always watching. Thank you very much. Philo Akita, Moses Abebio, Augustine Buedu says annual retinal checks and foot checks are very important. Yes, they are. Andrew Chumesi, hi Andrew. Andrew,
let me. You know the person who mentioned annual retinal checks. People, if you have diabetes, don't joke with it. If you don't have diabetes, you're getting blurred vision. You can tell yourself that now when you start reading, you can't see properly. Have an eye test done, or especially at night. One of the things with cataract, early stages of cataract, is that the person at night, it's affecting the vision. So things look a bit black. They are bumping into objects and whatever, but they are still sitting there. They are not having any checks done. If you are diabetic, when you get that letter to go for your retinopathy screen, don't thrash the letter before you develop blindness. Make the time, go for that eye check. Obviously, for those of you watching from elsewhere other than the UK, you will probably never receive any letter, but be an ambassador for yourself. Be, check your own self. And when things are not going right, they are not going right. So, Dr. Khan, I think we'll finish off now. But the compliments are amazing on here. Everyone they are saying you know your stuff. Dr. Khan is a GP in London, and he is
the most amazing GP, and he's fully in support and backing me 100% in this healthcare program. But we need you to be actively sharing and getting the message out there to people.
I think it's quite important. We have our Afro-Caribbean community is at risk. Many of the conditions we talk about here are conditions that are pertinent to us. That is why we pick them. The conditions that we are at risk of. Many of our people don't go to the GP for different reasons, a variety of reasons. And what we're trying to sensitize people that, look, much as money is good, your health comes first before money. And that people should look after their health. My take-home message would be, if you've not visited your GP for a while, please do. An hour a year is not too much. If you've been diagnosed with a condition, you've been placed on medication, please. Sometimes we have family. It is not just you. You've got children who are young. You've got people who depend on you. You may even have grandchildren. Make no mistake at all, your life is not ended. Sometimes even a wise word to a grandchild changes the destiny of somebody. So keep yourself fit, keep yourself well. Take your medication whilst we pray for our healing. Are you with me?
Yes.
Let's also take...
I like that bit. The spiritual aspect of the disease.
Yes. Whilst we pray for the healing until the healing comes. If there's medication that sustains, the Bible is loaded with so many examples of things being given to people to take. Are you with me? So whilst we're waiting for that healing, if there's medication you have to take to sustain yourself, please take it. But diabetes, if you have to take one medication, please diligently take it. Otherwise, you end up on several medications.
And several interventions.
So prevention is always better than cure.
Yeah. Wow. Dr. Khan, as usual, this has been awesome, an awesome session. I think we could have gone on and on and on.
So much to talk about diabetes.
One thing we avoid is mentioning drugs, in the management of everything, because everyone will be managed differently.
Everybody is different, As I said, the treatment is tailored to the individual.
So, Dr. Khan, thank you so much for
thank you, Winnie, for having me again.
I know you are coming back again. Dr. Khan, you are becoming my resident doctor, Thank you very, very much.
We have a commitment to the community.
We do have a commitment to the community. And
so we'll do the best we can,
Yeah, thank you so much. All this was by courtesy of World Remit, the safest way to send money to your family and friends back home, and also through Omega Live Multimedia, Omega House, Omega Live TV, and they have kindly given us this platform for all the health professionals to come and share their knowledge. If you are, of course, a health professional, doctor, nurse, specialist nurse, patient, because the patient accounts are always very good learning sessions for us, and you want to feature here, obviously you can send me a message through Messenger and I will arrange and bring you here on set. The next time we come, which will be in 2 weeks' time, on the 16th of October, I have got Mr. Richard Emisa. Mr. Richard Emisa is a mental health nurse specialist, and he is coming to look at all the complications of mental health in COVID, because apparently a lot of the youth have been struggling big time with a whole lot of social issues, and it's impacting big time on mental health. So he's kindly offered to come and give us an insight into how we can support.
And I think it's it's timely. That from where we come from, mental health is something that people just ignore.
We don't talk
about it. It's almost like it's a taboo to talk about mental health. What we fail to realize is that many of the young people who are our children cannot reach out to the parents. They can't reach out to us, but they're struggling. They are, mind you, they are not in Ghana. They live here. Under the conditions that are here in this country, and if we don't talk about it, we can lose them.
We can lose them. So Mr. Richard Emisa will be here, and believe it or not, let's talk about health. It's nearly a year old. It's been
amazing.
A year. Yeah, believe it or not, it will be a year old in about a couple of months.
Wow.
And it's been awesome, like all the people coming to share their knowledge and experience, their expertise. So I need you guys, whilst you are on live, to share with me how you want us to celebrate it, whether you want us to raise funds for a cause or you want us to do anything in health to celebrate this 1 year, because I think it's a big thing. I didn't even think I can come this far, and we have done a year already. So it's all been by your kind patronage. So please keep sharing so we get the knowledge out there. I am hoping to see you again in 2 weeks, but go back and watch what you missed, because I know so many of you were joining in late. If I haven't mentioned your name, I still appreciate you so much. So next time I will. But until we come your way again in 2 weeks' time, stay safe. COVID is up again on the increase. So please observe all the rules, stay safe, take care, look after yourself. And like I always say, work hard as if all depends on you, and pray hard as if all depends on God. On that note, I say thank you. Bye.
Bye.